Good afternoon and welcome to Baptist Health International's quarterly medical lecture. I am Dr. Gelrud Hakim, Assistant Vice President of International Healthcare Partnerships and Insurance Development at Baptist Health International. It is my pleasure to welcome all of you to this informative presentation. I would like to extend warm greetings to our friends across Latin America, the Caribbean, and everyone joining us today. During this interactive presentation, you will have the ability to ask questions via the Q&A feature located at the bottom of your screen. I will be your moderator for today's lecture. This afternoon, I have the distinct pleasure of introducing Dr. Andres Gelrud, who will be presenting a lecture titled "The Innovation in the Treatment of Pancreatitis," which is the approach during the critical hours and its outcomes. Dr. Gelrud is a board-certified gastroenterologist and the director of the Pancreatic Disease Program at Miami Cancer Institute, which is part of Baptist Health South Florida. He completed his internship and residency at Tufts New England Medical Center in Boston, Massachusetts. He then completed a fellowship in gastroenterology, pancreatology, and interventional endoscopy at Harvard Medical School, Beth Israel Deaconess Medical Center, and Brigham and Women's Hospital. He also obtained his master's degree in clinical investigation at Harvard MIT Division of Health Science and Technology. An internationally renowned expert in diseases of the pancreas, Dr. Gelrud focuses on providing care for acute, recurrent, and chronic pancreatitis, genetic conditions that lead to pancreatitis, complications from pancreatitis, pancreatic cancer, and pancreatic exocrine insufficiencies, as well as for general gastrointestinal disorders. He also provides both medical and endoscopic treatment options that arise from the pancreatic diseases. Dr. Gelrud is an expert in interventional endoscopy and endoscopic retrograde cholangiopancreatography, a procedure that helps to diagnose and to treat diseases of the bile duct and pancreas. He is highly skilled in performing transgastric pancreatic necrosectomy, a procedure to remove pancreatic tissues through the mouth using endoscopes rather than through abdominal surgery. He's also a leader in total pancreatectomy with the islet autotransplantation, which is used to treat chronic pancreatitis. Dr. Gelrud has written over 200 publications consisting of articles, abstracts, peer-reviewed journals, and textbook chapters. He is the co-editor of the Journal of Pancreas and sites of the board of the National Pancreas Foundation. He's also a member of the American College of Gastroenterology, American Gastroenterology Association, the American Pancreas Association, and the American Society of Gastrointestinal Endoscopy. Dr. Gelrud is, of course, fluent in English and in Spanish, and I would like to ask you all to give a warm welcome to Dr. Andres Gelrud, a great friend, a great partner. Welcome, Dr. Gelrud. It's such a pleasure having you in today.
Thank you so much, Galera. I really appreciate the kind introduction. I think it was a little bit long, but thank you so much. That's very nice. In simple words, I'm a clinical and therapeutic pancreatologist. That's what I like. That's what I do for a living. And the organ that I like the most in the body, it's the pancreas, as you just heard. So it's really a pleasure to be talking about pancreatitis today. And hopefully, in this afternoon, what I'm going to try to make very clear, it's how to make the diagnosis and how to treat the patients in the critical hours. I'm not going to go into the treatment of complications. That hopefully we can do at a later time. And that's actually a talk on its own, the complications of pancreatitis. But I want to make sure that all of you, wherever you are, you get a good glimpse on how to make the diagnosis and how to treat it. And I'm going to try to clarify some of the frequent mistakes that I see, in the hospital or the consults that I get, and looking back, what could have been done better to prevent a complication that now we have to deal with. So with any further ado, I'm going to divide the talk in defining what pancreatitis is. We'll talk, of course, about etiologies and how to make the diagnosis and how to treat it, and we'll go into some conclusions. And what I'm going to try to do throughout the talk is to give you take-home messages so you can remember and hopefully start to use them today or even tonight if you happen to be on call in the ER and you get a patient with pancreatitis. So how do we define acute pancreatitis? Acute pancreatitis is defined by the presence of two of the three criteria that I'm about to mention. Either abdominal pain that was triggered by a meal, frequently it's a fatty meal, sometimes it's alcohol, but the point is that the pain, it's very severe. It's usually 10/10, constant nausea, vomiting. In occasions, it radiates to the back. When I'm talking to my fellows, when I'm talking to my students, I usually, I tend to ask the patient, did a bomb went off? This is not a trivial pain. This is not a pain that lasts for a couple of seconds and then you pass gas from above or below and the pain goes away. No, 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 no. This is a pain that the patient ends up in the emergency department, begging for narcotics, begging for pain control because it's severe pain. Again, a bomb went off. And I know I'm exaggerating a little bit, but I want you guys, to get a strong message that it's severe pain. Then criteria number 2, it's imaging consistent with pancreatic inflammation. Criteria number 3, and again, it can be in any order, the elevation of the amylase and or lipase at least 3 times the upper limit of normal. Very, very important because there's many conditions in the body that will give you a mild elevation of the amylase and or lipase that does not represent acute pancreatitis. So 2 out of the 3 that I just mentioned, it's diagnostic of acute pancreatitis. By the way, and we can go into this in the question and answer, frequently, if you have the severe abdominal pain with an amylase and or lipase, over 3 times the upper limit of normal, let's say 10,000, 20,000, whatever, frequently you do not need to get a CT scan or any type of imaging studies because the diagnosis is there. In the real world, what we tend to see is that by the time that we're being involved in the care of the patient, the CT scan has already been performed. But this is something to keep in mind, particularly if you have a patient that may be on acute kidney failure because of the pancreatitis. You don't want to load the patient, with IV contrast, because if you're going to be getting a CT scan, you want to use contrast. Without contrast, it's very difficult to look at the parenchyma, and it's difficult to see the inflammation. Pancreatitis may be mild, moderate, or severe, and this is defined by the presence or how transient or how persistent organ failure is. If the patient comes in with no organ failure, no local or systemic complications, that's mild. And the good news is that between mild and moderate, we're talking about 90% of the patients. A moderate, it's a patient that may have transient, again, less than 48 hours, pulmonary problems, renal problems, hypotension, etc. And severe is the patients that come in with bad pancreatitis and they have organ failure. And we're talking about pulmonary, renal, or cardiovascular because those are the ones that we tend to see the most. So the other point that it's extremely important to clarify, it's what's acute, what's recurrent acute, and what's chronic. Because yes, they all share the same name of pancreatitis, but if you talk to somebody like me, these are 3 completely and absolutely different medical conditions, and they truly are. So one of the things that I want to try to give the knowledge today, it's to help you remind, conditions that lead to pancreatitis that we can treat to prevent the development or the progression to recurrent acute or even to chronic. I'm going to show some data, but again, this is very important. Acute pancreatitis, it's what we just spoke. 1 episode of pancreatitis and never again. Recurrent acute pancreatitis is a patient that had an episode of acute pancreatitis, had a complete resolution, they went completely and absolutely back to the normal, and then they develop a second episode or more of documented pancreatitis. So 2 or more episodes of acute pancreatitis, it's defined as recurrent acute. And then you have chronic pancreatitis, that is a patient with chronic abdominal pain, endocrine and or exocrine pancreatic insufficiency. And I'll be, again, more than happy to talk about chronic pancreatitis in a future lecture because, this is something that is close to my heart also. And I see, many of these patients, and I care for many of those patients. Again, before we move on in the etiology, I just want to talk briefly about the natural history of pancreatitis after the first attack. And I'm showing a paper that it's a little bit old from 2012, But when we're talking about 7,500 patients, I think it gives a very strong message. So this was data from the Pittsburgh group. I actually spent 6 years at UPMC with them, with this group. And this is, again, 7,500 patients. And they were looking at the etiologies of pancreatitis and what happened, after the first episode. What's interesting is this is something that we know, 28% it's biliary pancreatitis, and I'm going to show you in a couple of graphs and one of my patients what biliary pancreatitis is. Then you have 19% alcohol, people that are either alcoholics and develop their first episode, or people that binge alcohol and develop pancreatitis. And then 36, almost 40% were idiopathic. And here I just want to mention something. You're talking about 1996 until 2005. I can tell you that we have published papers showing that what was before 40% idiopathic, nowadays we know that there's a large percentage of genetic mutations in this group. Why am I saying that? Because nowadays that gene testing is so much cheaper and available. It's so easy to perform and much cheaper. We're realizing that what before we call idiopathic, nowadays it's really a genetic mutation that led to the pancreatitis. So what is a biliary pancreatitis? I don't know if you can look at my cursor here, but you can see here the gallbladder with a bunch of stones. So smaller stones may pass through the cystic duct, go into the common bile duct and get stuck here at the level of the major papilla. And then it's going to give backup pressure, triggering the pancreatitis. So this is a close-up view of the major papilla. What you see above is the minor. And what you see here is a small stone that left the gallbladder, got stuck here in the distal common bile duct and gave back pressure, triggering pancreatitis. The good news is that approximately 80% of these stones are going to pass on their own. And this is great news because the urge of doing an ERCP, it's no longer there, as we have learned based on larger studies, that 80% of these stones are going to pass on their own. And there's a subset of patients that, yes, we need to go within the first 24, 48 hours to do an ERCP to get the obstruction away, frequently the stone. So, and again, this is just showing a spontaneous stone passage. It's extremely important that this patient goes home without a gallbladder. So again, we're talking about the #1 etiology of pancreatitis being biliary. And I want to give you a very strong message that you have a patient with biliary pancreatitis, make sure they go home without a gallbladder. You don't want the patient to go home with a gallbladder that was the source of the pancreatitis for them to develop pain again in a week or two and to be readmitted and potentially have severe pancreatitis. So this is one of my patients that I did, I don't remember exactly when, but you can see a stone impacted here with a huge bulge in the major papilla. This patient actually came in very sick with elevation in the transaminases, elevation in the white count, febrile, and the bilirubin was elevated. You can see here that I'm doing a sphincterotomy, and you hopefully saw already the river of, and fill in the blank, that it's coming out. You're gonna see it better in just a second. That drainage that you see there, it's literally pus coming out. And look here at even more pus coming out. So again, are we treating the pancreatitis? Are we treating the stone? Or are we treating ascending cholangitis? That we know that ascending cholangitis is a medical emergency. So independent on the etiology, you have to go in and treat and decompress these patients when they have ascending cholangitis. In this particular case, and here you're gonna see the stones coming out. I don't know if you saw it, but that's a brown stone in the left lower quadrant of the screen. And there you go, you see it better here. And you see my balloon that we use, to clear the stone. So again, this is biliary pancreatitis in a patient that had an impacted stone. And on top of that, the patient had ascending cholangitis. Why am I talking? And again, this is the extreme of the cases, but I happened to videotape this beautiful case, so I wanted to share it. Why am I talking about this and making so much emphasis that the patient had a bilirubin elevation, that the patient had a white count, febrile, etc.? It's because there's a couple of studies looking at which one are the patients that truly benefit from an ERCP in the early setting. And we're talking about 24, 48 hours. When you look back and you do subset analysis, the patients that benefit the most are the patients that had the underlying biliary pancreatitis with ascending cholangitis. So the question always is, you know, these patients got better because you treated ascending cholangitis, or did this patient get better because you remove a stone from the bile duct that was obstructing, leading to pancreatitis and ascending cholangitis? Again, the verdict, it's not 100% out there, but this is what we do. Again, 80% of the stones are going to pass on their own. The patient is admitted, elevated LFTs, elevated bilirubin. If you have the luxury of doing an MRCP immediately, you're going to have the answer. So you know if you need to go in, you know, sooner rather than later. But if you don't, just check another LFTs in a good 6 hours and see what the trend is. Because if they're going up, I would take this very seriously, and I would do an ERCP with decompression sooner rather than later. And again, we can go a little bit more into details in the question and answer section, but I just want to provide the message that not everybody with biliary pancreatitis needs an ERCP. And yes, I do ERCP for a living. So you're hearing this from our therapeutic endoscopies. So moving along with the same study, what was interesting from this study is that approximately 30% of the patients are going to be readmitted after the first episode. There's also progression to chronic pancreatitis, but it's very rare. What's interesting is that who are the patients that tend to progress into chronic pancreatitis? Those are the patients with recurrent acute pancreatitis, the patients that are alcoholics and continue to drink, or the smokers. And very, very rare, the biliary pancreatitis or the patients that had anatomical malformations like pancreas division. So take-home message is that, you know, and that's one of the conclusions, is that we can change the natural history of the disease if we do early behavioral intervention. And what do we mean by that? Again, making the, you know, finding a way to have the patient stop smoking and drinking, both of which are very tough, but when they stop, I mean, you may stop the disease progression and they may not have pancreatitis ever again. So just keep this in mind. This is very important. The other thing that I wanted to mention, it's recurrent acute pancreatitis, that a subset of patients in this study, when they came back, they had biliary pancreatitis and the gallbladder was never removed. So again, another take-home message that I'm repeating now for the second or third time is that if you have a patient with biliary pancreatitis and you don't want them to come back to the hospital with another episode of biliary pancreatitis, make sure they leave the hospital without a gallbladder. And again, we're talking about the 90% of the patients that had a mild pancreatitis. If you have a patient with biliary pancreatitis and organ failure, listen, there's no, you know, a persistent organ failure, that they have severe pancreatitis, there's no hurry on removing the gallbladder. Here we're talking about the patients that they have a mild episode, they get better fast, and they're going to be ready to go home in 3, 4, 5 days. Again, this is the TIGAR-O classification that we use for the etiologies of chronic pancreatitis, but it also applies for acute pancreatitis. Again, TIGAR-O, you can see what this stands for. There's a revised version from 2019, also from Dr. Wickham, but I didn't want to change it because this is the original graph. And T stands for toxic and metabolic. Again, smoking, smoking, smoking. You have to convince the patients to stop. You can help them if you are in primary care. You know, there's multiple things that can be done nowadays. Also for alcohol, metabolic, remember hypertriglyceridemia. It's something that we tend to miss, and it happens a lot, particularly in patients with poorly controlled diabetes, and they come in with pancreatitis. We see it frequently. Keep it in mind. Hypercalcemia, if it is a patient with some type of paraneoplastic syndrome, maybe the initial presentation of a tumor. You make the diagnosis early, and you may treat the patient early, and you may be doing a great service to your patient. I, for idiopathic, you know, it's always going to be there. Remember what I told you, that the piece of the pie for idiopathic is shrinking. What's getting bigger and bigger and bigger is the G for genetics. And here we have a milieu of different gene mutations. There's a company now that it's international also, that it's called Area Precision Medicine, that you can use them to do genetic testing, even if you're in different parts of the world. And you can look that up in the internet. You have A for autoimmune, that used to be one of the new kids in the blog. Now we're seeing this with much more frequency. We're recognizing this entity, and this is something that we treat with steroids, recurrent acute or severe acute pancreatitis. And O, you have trauma, tumor, stones for obstruction. So just remember that, because this is all different etiologies, that if you make an early diagnosis, you may change the disease progression. Just keep that in mind. This is a slide that is super important. I will take notes. This is the basic workup that we do for patients with acute pancreatitis when they come to our ER. You want to check a TSH, you want to check a calcium, you want to check tissue transglutaminase and an IgA to rule out celiac disease. And yes, they're unusual, but this is the type of things that if they don't have biliary pancreatitis, if they're not a smoker, if they're not heavy drinkers, you want to do this study because you want to make sure they don't come back and that they get treated sooner rather than later. This is triglycerides, as I say, IgG4 for autoimmune pancreatitis, and genetic testing in a subset of patients, particularly if there's a family history of pancreatitis, particularly if this is the second episode. I can tell you that in my clinic, when they don't have biliary pancreatitis, they're not alcoholics, they're not smokers, I'm doing genetic testing nowadays sooner rather than later, because it's so cheap and so available that I prefer to do it and have an answer for the patient instead of waiting for more episodes to happen. This is another thing that I wanted to make very clear and that I want you guys to take note. And please don't forget about this, because you may be doing a huge favor to your patients. Here we're talking about 500,000 patients from the Veterans Administration Hospital here in the US, the VA system. And the take-home message is that there was a group of patients that were admitted with acute pancreatitis. There was no diagnostic made, so they were called idiopathic. And within 2 years later, they came back with pancreatic cancer. So what's the take-home message here? By the way, there's multiple studies showing this. I like to use this one because it's such a high number of patients. But what's the take-home message here? You have a patient with pancreatitis, wait at least 1 month for the pancreatitis to completely resolve, and then get some type of imaging study of the pancreas to look at the pancreas and make sure that it looks beautiful and that it looks completely back to normal. Why? They may have a tumor. And again, it's not always adenocarcinoma. It may be an IPMN that you didn't see, it may be a small neuroendocrine tumor, but the point is that you may have a diagnosis of a tiny tumor that you can treat early on, instead of, the patient coming a couple of years later with a big tumor that may be metastatic by the time that you make the diagnosis. So just keep that in mind. Again, when do we do radiology? When do we take images? It's not always needed in the ER, but it's frequently done. Obtain a pancreatic protocol CT scan, wait at least a month for the pancreatitis to be resolved if you're looking for a tumor. Frequently, if you do it early on, the inflammation may mask a tumor. So you want to make sure, again, that the inflammation is subsided. That usually takes a month, and then get a good imaging study. You may get a pancreatic protocol CT. You may get an MRI with IV contrast. If you have it available, you can do an endoscopic ultrasound, etc. And I'm only measuring ERCP in the patients that I showed you before. It's only indicated for therapeutic purposes. You don't want to do an ERCP for diagnostic purposes. And we tend to do this in the first 48 hours in patients that the bilirubin is going up, patients that are sick, patients that are blocked, patients that you think may have ascending cholangitis. And remember, 70–80% of the stones are going to pass on their own. Again, the early treatment for these patients, this is the other thing that I really wanted you guys to remember and take it home with you, and hopefully start to use it tonight if you're on call, or tomorrow, when you start to see these patients. Hydration, hydration, hydration. It's what's going to really save parenchymal pancreatic tissue and prevent long complications in the long term. Hydration also, it's what's going to help perfuse the kidneys and prevent acute kidney injury. And the analogy that I like to give when I'm talking about hydration, it's a patient with an MI. The earlier you open those arteries and you reperfuse that heart, the better the patient is going to do in the short and in the long term. Again, in the world of the pancreas, the more hydration you give and the better perfusion you have to the pancreas, the better this patient is going to do. And there's plenty of studies, we can go on and on in literature. I just wanted to keep simple and give you a very strong message. Ringer's lactate, it's much better than the others. So if you have it available, use it. If you are dealing with adult, start with 2 liters, and then you can decrease to a liter within 2 hours. You want to follow the BUN to make sure that it's trending down or that it remains normal. That's the best marker for in-hospital mortality. Again, I don't want to overwhelm you with information, but what I want you to remember is that when you have a patient with pancreatitis, before you call a consult, before you put an order for a CT scan, if the lipase came elevated, the pain is typical, give 2 liters of Ringer lactate as soon as possible because these patients are intravascularly depleted. Yes, they may be fluid overloaded because they may be extravasating in the third space, but in general, they're intravascular depleted. So you want to preserve the pancreas parenchyma and perfuse all of the organs to prevent complications in the long term. Early nutrition is what we do. And yes, you can start PO the first, second day if it is mild and the patient has an appetite. The sad reality, it's frequently they have nausea, vomiting, they may have an ileus. So if you try to feed them, they may vomit, and they're going to get very sick. In that subset of patients, you may want to start enteral feeding with a nasojejunal feeding tube. Yes, you can do nasogastric tube also, but we have more experience with nasojejunal, and you can trickle the patient. And remember, enteral feeding, it's much, much, much more preferred than parenteral nutrition. So just keep in mind, you want to use the guts, you don't want to use the veins when you're giving food in this patient population. The typical question and the typical mistake we see, it's patients coming with pancreatitis in the early setting, and we're talking 48 hours. They have a fever because they have severe inflammation. Everybody gets nervous and they start antibiotics. There's multiple studies showing, including meta-analysis with thousands of patients showing that we do not need to give antibiotics in the early settings. If you think the patient may be infected, for this pancreas to get infected, it's going to be at least 5, 7, 8 days after the hospital admission. If they come in with a fever, it's because they have severe inflammation from pancreatitis, extremely unlikely for them to be infected. So unless you are thinking that they may have ascending cholangitis, which is rare, there's no need for antibiotic use. Again, there's multiple great quality publications that you can look up in PubMed, or I'm happy to share the references if you want. So the medical treatment after discharge, the patient got better, was in the hospital 1 or 2 days, they got hydrated, pain control, they're eating, they go home. Again, if they're drinking, they have to stop drinking. If they're smoking, they have to stop smoking. And I always tell the patients, sarcastically or jokingly, every time you drink or you smoke, you're basically asking your pancreas, give me pancreatitis, give me pancreatitis. And believe me, you're going to get pancreatitis again. So, this is something that we have to push the patients. They need to seek help. If they're smoking, they can go to their primary care doctors and give some type of medical treatment. They need to be, of course, very motivated for both. Alcohol, it's a different creature, but I can tell you a lot of patients do stop drinking. A lot of patients do stop smoking. So just try to encourage them. Don't criticize them, encourage them, and you may have great results. ruled out. Again, make sure that if you are not the treating physician, when you see them in the hospital, make sure that celiac was ruled out, triglycerides were ruled out, hypercalcemia, hypothyroidism. Sometimes patients with lupus, 5-7% of them may come in with pancreatitis from vasculitis. Look at the images, make sure that it doesn't look like autoimmune pancreatitis. Check an IgG4. These are conditions that are relatively easy to make the diagnosis and easier to treat. In occasions can be very tricky to make the diagnosis, but they're easy to treat when you make the diagnosis. What about antioxidants? There's a couple of randomized studies that were beautifully performed that showed that it doesn't work, and some others that were beautifully performed that showed that it worked. So what do? I tell my patients, take it. Why? Because if it doesn't work, it's not going to do any harm, and they're relatively cheap. So they can take any type of combination of antioxidants that are over the counter, and I tell that to the patients. What about the use of pancreatic enzymes? For the mild pancreatitis, never use them. Uncover enzymes do not prevent the recurrence of pancreatitis. There's a study ongoing right now, multi-center, looking about the use of pancreatic enzymes in very sick patients. Again, the severe pancreatitis, again, the 10% of the patients. I think that it's going to show that, yes, it works. Yes, it helps. Why? If you have severe pancreatitis, you cannot expect the pancreas to start to work at the full potential immediately after discharge. So again, in my head, I'm thinking that it's going to work. Let's wait for the data to be published. What about nutrition? Hydration, it's pivotal. And I tend to tell the patients, stay in a low-fat diet for at least 1 month. And when they ask me what low-fat diet means, I tell them, listen, I don't want you to think that, eating a greasy pizza, it's low-fat. I don't want you to think that eating, a steak with a bunch of fat, it's low-fat. Just use common sense and try to keep it very healthy to make sure that your pancreas heals and it goes back to normal. So to conclude, make sure that you're making the diagnosis of the right medical condition. Acute pancreatitis, 2 out of the 3 criteria, as we mentioned before. Severe pain, that it may be a bomb went off in the patient's abdomen. Amylase N or lipase, 3 times the upper limit of normal. Imaging showing pancreatic inflammation. Always look for treatable conditions, as we just spoke. You want to make the diagnosis. You want to try to find something that you can treat to prevent the acute from becoming recurrent acute, and even more important, from becoming chronic. Always, always, always do the basic workup. And again, here in the US, I'm doing more genetic testing as the cost has significantly decreased and it's being covered by insurance. Hydration in the acute setting. It's very cheap. You have it there, use it. Lactated ringers, it's better. And of course, pain control, they come to us because they have severe pain. There's no need for antibiotic in the first 48 hours. And I would say even the first week. Remember, of course, if a patient has ascending cholangitis, that's a different creature. If biliary pancreatitis, uncomplicated, make sure that the gallbladder is out before the patient leaves the hospital. Very, very important. Remember also acute pancreatitis in patients older than 40 years. Always keep pancreatic tumors in mind. So get a repeat CT and MRI with IV contrast a month later, just to make sure that everything is back to normal and there's no bad surprises like a small tumor. And again, when in doubt, talk to your pancreas team if you're lucky and you have one, or refer them to a pancreatic disease center, or feel free to contact me. Believe me, I do a lot of chatting by email or by WhatsApp, with different friends that I have in Latin America, in Central America, also in Brazil, actually, from different conferences that we have worked together. So it's always a pleasure to be able to help, get our patients better. And particularly when we don't really know what to do, because we're not doing this all the time. And some patients can get very sick, as I'm sure many of you here in the presentation may have seen it in your own practice. For those of you that speak Spanish, go to the National Pancreas Foundation. Actually, for those of you that speak English only, go to the National Pancreas Foundation. We created these videos that you have here. 18 years ago, it was two of my friends and I that we started this. Nowadays, and I would say approximately almost $2 million later, we have a beautiful website in English, in Spanish, on acute pancreatitis, chronic pancreatitis, pancreatic cancer, endoscopic therapies. Take advantage of this. It's greatly done in the information. It's trustworthy. It's good for students, for practicing physicians, for the patients. We use it all the time. And with this, I'm going to stop. And again, thank you so much for taking the time here to joining us this afternoon. And if you have any questions, I'm more than happy to help. And if you have any patients in the future, I'm also more than happy to help, even by text, even by WhatsApp, email, or find a way that we can talk and we'll get the patient forward. We'll help the patient. Take care and thank you for joining us.
Dr. Gelrud, what a great recap of one of the conditions that we see the most in our hospital system. It's remarkable what you can actually achieve by early identification and treatment of pancreatitis, and obviously the future prevention of even more complex type of processes. One thing that always comes as a common denominator during our conferences is that it is absolutely mind-boggling, the fact that the sequelae presented by patients due to cigarette smoking and alcohol consistently have a immediate allocation to that particular disease as a risk factor. So your message was loud and clear, especially to all our students participating today. I know that it is a challenge, and now the shift in public health has been somewhat less on smoking and alcohol and drug abuse because of obvious reasons through the pandemic. But it is absolutely important, the message you gave us, Dr. Gelrud, to counsel our patients in regards to cigarette smoking.
And let me mention also something, because it's a good point that you're making, but also remember that it's a very small percentage of patients that drink or smoke that are going to develop pancreatitis. So the sad reality is that it's a disease and that we see it frequently. But for the medical students listening to this talk, I want to make sure that when the patients tell you, that they don't drink, they don't smoke, I personally believe them. I'm always with a good intention that if you tell me you don't smoke, if you tell me you don't drink in excess, I believe you. So it's important to look for other causes, because as I'm getting older, and I have been doing pancreas work already for 23 years, because early in my fellowship, I got interested in this. I can tell you that it's very sad when a patient tells you, I'm not an alcoholic, I'm not a drinker, and then you read in the note, that the patient is denying that they're an alcoholic and that they must be an alcoholic. Why? Because you as a physician are not thinking about everything that we just spoke now, which are other conditions that lead to pancreatitis. So you think the patient may be a drinker, you think they may be an alcoholic, and that's just not telling you the truth. I may be naive, but I can tell you that if they tell you they're not a drinker, they're not smokers, look for other etiologies and go for the side of believing what the patient is telling you instead of doubting that, because it's sad when I have patients, saying, everybody thinks that I'm an alcoholic, everybody thinks that I'm a whatever. And when you do a workup, you realize, wow, you know what? They have a genetic mutation that is closely related to pancreatitis later in life. But, just keep that in mind. Keep it in mind.
Those are definitely great points, because obviously as a physician, you will be deterred from actually thinking of the right condition if you start second guessing what you just heard from the patient.
Agree.
Great point. The other pearl that I believe that we all should take is the fact that you did mention that no antibiotics in the first 48 hours or the first week. More often than none, in some of our countries, that perhaps is the initial knee-jerk reaction of an internist or a primary or attending or an emergency physician that immediately, let's start the patient on antibiotics. Can you talk to us a little bit more about why would you say no antibiotics in the first 48 or perhaps a week?
That's an excellent question, because it's a mistake that it's frequently done. And I can tell you, when I talk about acute pancreatitis and I mention this, there's always angry people there in the audience saying, you know, what is he talking about? The patient may be infected, whatever. In acute pancreatitis, fever, it's driven mainly by interleukin-1. There's also other interleukins that are playing a role, but you have to remember there's a huge cascade of pro-inflammation that was triggered by the activation of the enzymes within the pancreas instead of the duodenum. And I'm just saying that because in the pancreas, the pancreas, it's not capable of protecting itself when there's such a release. So what I'm trying to say is that it's impossible to differentiate fever from pancreatitis, from fever, from infection. So we know that infection doesn't trigger pancreatitis unless you're talking about viral infections and things like that, which is not the case. You know, we're talking, just to keep it simple, it's very rare for that to happen. And if you're thinking about coronavirus, yes, I have seen a ton, and we can go into more details, but in general, and this is what it's important, what you're going to see in the real world, the vast majority of the time, it's impossible to distinguish fever from pancreatitis, from fever, from an infection. And if you look at pancreatitis patient and you look at the viral signs, what you're gonna see is that these patients have frequently, particularly the severe ones, severe inflammatory reactions that are systemic. And it's impossible to differentiate between acute pancreatitis and sepsis. And if you look at the parameters, they're more or less identical. The difference is that you know that they have acute pancreatitis because you made the diagnosis. So the fact that you know that it's acute pancreatitis and not sepsis, the fact that you know that the fever, it's because of the pancreatitis and not because of infection, you can take the risk of not giving antibiotics for the first 48 hours, up to 5, 6, 7 days, and just seeing how the patient does. Because if you tell me the patient came in sick with fevers, etc., and they got better in 2 days, why give antibiotics? And again, that's the vast majority, that's 80, 90% of the patient. But if you have a patient that is getting worse and worse and worse, and they don't have cholangitis, they don't have anything else, and you tell me that's why you gave antibiotics, I'm not gonna argue with you. But in general, no need. And believe me, if you're gonna give it, it's because they're not getting better. And very likely those patients are gonna be the 10%, the 20% of patients that develop severe acute pancreatitis. The vast majority are gonna do great. And remember also hydration, 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 and of course, pain control. Pain control, that's why they came to the ER. Absolutely. So that's an excellent observation.
Thank you, and absolutely, you're correct in that sense. And perhaps that is in some areas, in some countries, especially in the outskirts where they're not close to the capital, those physicians that are isolated from technology or means of actually diagnosing a condition, there is a very small window for them to initiate a protocol. One of the things that we always take for granted is obviously technology. It's obviously the advancement and in your case now favoring genetic mutations as one to be investigated. What would be your message, aside from the great list of things that you have compiled for us, what would be your message in regards to encountering these type of cases where you would say, you know what, this patient will benefit from an ERCP, and definitely I need to think of a cholecystectomy thereafter, or whatever you as a surgeon determine. Can you talk to us a little more about that?
Let's start with the genetic part, because that's something that we don't see frequently. And that's something that we're starting to see more and more and more, because the cost, it's so much cheaper that, you can do it. And it's being covered also by insurance companies. So if you have a patient that has a family history of cystic fibrosis, a family history of pancreatitis, a family history of pancreatic cancer, those are patients that would be a knee-jerk reaction. I'm going to do genetic testing. Absolutely, yes. You have also some patients that they tell you, doctor, you know what? I drink, I don't know, 1 glass of wine every night. or patients that tell you I smoke very little, and then you do genetic testing and you see that they have mutations that put you at very high risk of pancreatitis when it's mixed with, particularly with alcohol, because there's a bunch of mutations that we have learned that are tightly linked. So those are patients that are great because you know that if you continue to do whatever you're doing, you're gonna get into trouble. So that's very, very important. So you can really push the patient to change their behavior. That's for genetic testing. By the way, I'm a firm believer. I love genetics, and I can tell you that 3 years ago, the first treatment for genetic mutations became commercially available. It's for cystic fibrosis mutation, but I can tell you that there's more to come. And I hope that within my lifetime, I'm going to be able to tell you have a CFTR mutation, take the purple pill. You have a SPINK1 mutation, take the blue pill. You have a PRSS mutation, take the pink pill, whatever, And I hope that I'm going to be alive, but I can also tell you that when I was young, if you told me that we're going to have an iPhone or a Samsung or whatever in our hands and that you're going to have a computer, I would tell you, yes, I'm sure. And I wasn't going to turn around and call, the police because you're crazy. That's impossible. Or to be doing what we're doing now, when we were kids, never. I mean, that idea, you had to have a problem, and long story short, look where we are. So why do I mean by that? All of us that do genetics, we all have data banks. All of the genetic testing laboratories, they keep the banks also. And as soon as new genetic treatments become available, this is what's going to be done and the patients are going to be contacted. And by the way, a very good example, it's what are the vaccines that we're getting now, for coronavirus? They're all mRNA. When in the world, this is first in kind. So genetics, I think that's where the future is,
It is indeed. And that was one of my closing remarks as well. How exciting it is to our generation of physicians to actually look into not only technology, but the advent of new research in genetics. Charmaine has a question. Can you please say what is the percentage of patients who return with adenocarcinoma or pancreatic adenocarcinoma or other cancers?
That's an excellent question. I can tell you that starting at age 40, when you do a workup and everything comes back negative, get an MRI with IV contrast, get a CT scan, pancreatic protocol within a month. Again, once the inflammation has subsided, so you can see. I don't remember the exact number. I can tell you that at age 40, it's very, very, very low. But as the patients get older, the percentage starts to go up, not like this, but it starts to go exponentially higher. And I forgot to mention something that actually, it's very good that you bring that question up. If the patient has newly diagnosed diabetes and the patient is not an obese patient, think about pancreatic cancer also, because there's multiple studies that have linked late onset diabetes in patients that have no risk factor for diabetes with pancreatic cancer. And there's a beautiful study in gastroenterology that I think it's from 2010, 2011, from Suresh Shiari. At that time, he was at Mayo Clinic, that he was able to show that. And after that study, there must be another 10, 15, 20. And again, I showed the one that I showed because it's 500,000 patients. I don't remember the exact number to answer your question. At age 40, it's very low percentage. But as we get older, the percentage starts to go up. And it's no joke because, again, I have an interest in the pancreas, but I see it all the time. So I'm a little bit biased because I see so many. But I can tell you that I see pancreatic cancer as a trigger for pancreatitis frequently, particularly in the older patients. I'm talking about above 60, 70, 60 for me nowadays, it's truly, young patient. You have patients that look great at that age and they still have a lot of life ahead of them. But that's one of the reasons it's so important to make the diagnosis at 60 or low 60s, because they're going to sustain a surgery that very likely they're going to do great. And then you cure a potential nightmare, a potential disease that could have killed the patient. So that's a great question.
It is indeed. Valerio is wondering, is it necessary to remove the gallbladder with biliary sludge after severe acute pancreatitis? I believe you answered that, but yes.
Absolutely, yes. And for me, sludge equals small stones. So stones, I want the gallbladder out, particularly if the LFTs went up when the patient was admitted with pancreatitis. Because if the LFTs were completely and absolutely normal, and if you tell me why, you're going to remove it if the LFTs were normal at admission, I'm not going to argue with you because you're right. I mean, I would be very diligent in doing a full workup. But again, the likelihood that this was biliary pancreatitis, it's high. And for me, sludge equals small stones. And again, of course, there's a difference, but I'm just telling you that, kind of like to give you a very strong message. I want that gallbladder out.
Armando is wondering, when do you consider surgery in patients with acute pancreatitis?
What type of surgery? Are you thinking about cholecystectomy? Are you thinking? And I'm sorry to ask that because I don't know if you're asking about complications from the pancreatitis.
You're absolutely right. The variabilities, Armando, is there for you to choose from.
Exactly, Armando, because if you're talking about cholecystectomy, once they get better, take it out. But if you're talking about complications from acute pancreatitis, that they tend to happen a month after, and we're talking about cirrhosis, we're talking about walled-off necrosis, that's a different creature. And we can ask Dr. Hakim to invite me back, and I'll be happy to talk about complications of pancreatitis, because that's I'm not going to say every day, but at least 2-3 times a week, I'm dealing with complications from pancreatitis and drainage or necrosectomies and things like that. But I'm assuming that's what you meant. But hopefully we'll do it in a talk.
Pancreatitis, Dr. Gelrud, you know that you're always invited. It is, this is your forum, and we would love to have you over and over.
Thank you.
So Armando just responded. He goes, acute pancreatitis, biliary acute pancreatitis.
Got it, Armando. So remember, I want that gallbladder
out. Harold is also saying pancreatitis or biliary etiology, when to operate. So there we go.
It's a recurring theme because that's what we see in the real world. I mean, that's what we see every day. That's a real world. So remember, once they get better, within the same hospitalization, have one of your surgeons and do a laparoscopic cholecystectomy. That's a 30-40 minute procedure, and most of the times are very straightforward, So have your surgeon see the patient, remove the gallbladder, and hopefully you won't see the patient again. You'll see them in clinic and they'll be happy with you.
Absolutely. One last from Melvin, and he says, hello, how should the long-term diet of these patients be?
That's a very good question. Depending on the etiology, I tell them for the first month, just stay in a low-fat diet, stay well hydrated. How do you know you're well hydrated? Because you're peeing frequently and it's clear. I don't like to go into, you need to drink a gallon or 2 gallons. I don't like to go into that. I just tell them, make sure that at least you're drinking a full glass of water in the morning, at noon, 1 in the afternoon, and 1 at nighttime with dinner, and that the urine looks clear and not, and not dark. And if you're in the tropics, that you're sweating and the humidity, you're going to need most likely more, So common sense. And I tell them to be strict within the first month with diet, low in fat. And again, I'm talking about common sense. So we let the pancreas completely heal. And I'm going to tell you something. If they're not alcoholics, I would tell them after a month, they can start to drink again in moderation. And I tell them just drink a glass of water before you drink a glass of wine or a beer or something like that. Because some pancreatologists like to be very strict and they say, you know what, if you have pancreatitis, never again. I was not raised like that. That's not the way that I was taught, and I think it's reasonable. And I think that patients with pancreatitis, they respect, what the condition is. They don't want to have it again. So I'm sure most of them are doing the right thing.
Yeah, you did say, or you did start by saying it's a pain as if it was a bomb. So it is unbearable. So I'm sure they're not going to go through that again. Dr. Gelrud, you know that we love having you. You know that we enjoy listening to you. You're one of our greatest speakers. And,
Thank you.
and we are so fortunate to have you among our great team of physicians at Baptist. And for that reason, I am going to say you are cordially invited to our next one. So find a theme and we will do as you please.
Thank
And
you.
meanwhile, we're going to let you go just because we want to be considerate to you and to all our participants. And on behalf of our entire team at International, thank you for participating today. And for those that would like to send questions directly to Dr. Gelrud, please send them to BHIWebinars@baptisthealth.net. We will make sure to forward those questions to Dr. Gelrud. Again, that is BHIWebinars@baptisthealth.net. Very simple. We look forward to seeing you at our next quarterly medical lecture scheduled for Wednesday, February 16th, 2022. Thank you once again. Stay safe and please get vaccinated. Help us out. Thank you, Dr. Gelrud. Have a wonderful holiday.
Thank you for the invitation. Take care, guys. Bye-bye.